According to our knowledge of developmental milestones, children come to grasp the permanence of death at about the age of 7 years old. So when, as a medical student, you are asked to go see a 7-year-old in the emergency room with thoughts of suicide, there is no lecture or textbook that quite prepares you for that conversation with someone so young. But unfortunately, this is becoming increasingly common among youth in the US. Not only are rates of mental illness among children and adolescents increasing, but reliance on the emergency department, or ED for short, for behavioral health concerns has been increasing in parallel. And despite their design as an acute care facility, EDs across the country have somehow become behavioral health facilities. And we stand at a crossroads where we must decide as patients, providers, and taxpayers what the role of the ED should be. And in order to correct its current trajectory, we must understand how EDs are being used. Specifically, what I want to understand is what actually happens when a child comes to the ED with a behavioral health complaint. And in order to figure this out, I connected with over 40 different people at 13 different local EDs. I asked doctors, nurses, social workers, case managers, and everyone in between the same exact open-ended questions in order to figure out what a typical experience would be like for a child who comes in. And here is what I found. This process is largely the same across all of the EDs. As you can see in my slide, patients arrive in one of several common ways. They are asked a series of standardized questions during triage, which identify them as a behavioral health patient. They are then seen by a medical provider who will decide whether or not they should have a psychiatric evaluation. And this psychiatric evaluation can occur via telepsychiatry or an in-person team. Recommendations are then made and the patient is either sent home with follow-up or they wait for a hospital bed. Now, what makes a big difference in how this process plays out are actually the resources available to each of the EDs. This process looks very different when an ED has a locked behavioral health area with a day room and activities for patients to do while they wait for a hospital bed versus an ED that only has medical space to spare. In addition, there's an important difference between an ED that actually has the ability to have in-person behavioral health services versus those that are forced to rely solely on telepsychiatry. And in order to investigate these differences further, I have two different approaches that I plan to implement. First, I have 7 years of medical record data from these same local EDs, and I plan to use that data to look at how well these models of care, which we now better understand from the interviews, are actually performing. I plan to look at how long this process takes and how long kids have to wait and where these kids are actually ending up afterwards. Second, because of these in-depth interviews, I've actually been able to develop a 10-minute survey that's going to look at the same exact process, but across all of the EDs in North Carolina. And so I plan to distribute this to the over 120 locations later this year in order to find out more information about what's happening on the ground. Because only once we understand what's happening on the ground can we identify tangible and realistic gaps in care that can actually be addressed through policy change and resource allocation. This is the first step to redefining what the ED means in terms of behavioral health care. Thank you.